more readily in certain areas than other. And then tonight, we're dealing with a systemic disease, which is a factor that has a great implication on immune fitness of the patient involved, because basically what diabetes does is it basically causes an aberrant host response, whereby you have a hyper-responsive host in terms of inflammation, and you have a lack of tolerance to the biofilm, which then becomes dysbiotic, and it is referred to as a dysbiotic microbiome, which then leads to a fulminant periodontitis and breakdown of connective tissue and alveolar bone, which is the hallmark of periodontitis. Diabetes mellitus, just a simple review in terms of its definition and pathogenesis, less so the pathogenesis. It's a group of metabolic disorders characterized by hyperglycemia, and this is usually due to defective insulin production or the action of insulin, or both. It is defined when you have a fasting plasma glucose of above 100 to 125 milligrams per deciliter, or an HbA1c above 6.4%. We are well versed in the fact that there are different types of diabetes, and each has their own pathogenesis. Type 1 diabetics are usually occurring in younger individuals due to usually autoimmune destruction of the beta cells of your pancreas and the inability to produce insulin. Type 2, due to insulin receptors not able to accept the action of insulin. And this is usually later on in life, and they have some lifestyle issues associated, like obesity. Gestational diabetes that occurs in pregnant women, usually diagnosed around the 5th month of pregnancy. And then other types of diabetes, such as secondary to long-term corticosteroid use, as well as neonatal diabetes, which is less prevalent when you're looking at the relationship to periodontal diseases. There's an interesting group of patients that are considered pre-diabetic. And what the stats are showing is that 2/3 of those affected by pre-diabetes usually convert to diabetes within a 3-year period. In terms of complications that severely affect quality of life, these include dehydration, poor wound healing, myocardial infarction, stroke, limb ischemias, kidney disease, neuropathies, neurocongenitive decline, hyperosmolarcoma, retinopathy, and serious foot infections. And until very recently, periodontitis was a part of that list of complications, but it's no longer considered to be a complication of diabetes mellitus. And I came across an excellent review by Pollock et al. And there was a sort of term that he said, periodontitis and diabetes, comorbid old friends. And I thought that was actually quite a cute play on words. And most recently, the American Diabetes Association reported that periodontitis is in fact a comorbidity with diabetes mellitus. And epidemiologists are still not all agreeing to what the definition of a comorbidity is. But in short, if I could try to explain, a comorbid disease or comorbid diseases either occur simultaneously, but they can occur independently, or they can be related to each other with respect to things like risk factors or complications. When we're looking at periodontitis and diabetes mellitus, they are both multifactorial, but we all know that periodontitis is prevalent without diabetes mellitus, yet it becomes more prevalent in the presence of severe forms of diabetes mellitus. And the basis of this relationship in terms of this friendship is inflammation. And the understanding of inflammatory mediators and how they work is of utmost importance when we look at this particular relationship. When you look at diabetes mellitus, there is impaired inflammatory and immune responses as well as impaired healing. And in periodontitis, you have unbalanced inflammatory or immune response that give rise to dysbiotic flora that then further drive the process of disease that we know to be periodontitis. So it is well understood that periodontitis and diabetes mellitus has a bidirectional relationship. And by this, we mean that periodontitis affects the diabetic's ability to control the diabetes, and in turn, the diabetic patient is more prone to a more severe form of periodontitis or periodontal infection. When we speak about the importance of diabetes mellitus and periodontitis is highlighted in our new periodontal disease classification of 2017-2018, whereby diabetes was included with smoking as a grade modifier. And the objective of grading is to basically use whatever information is available to determine the likelihood of this case progressing at a greater rate than in a typical or majority of the population, and also responding less predictably to the standard of therapy in terms of treatment of periodontal diseases. So when you present with periodontitis and you are diabetic, you immediately get placed into a grade B category. That doesn't matter whether you are well controlled or not. A poorly controlled diabetic will then go to a grade C, which is actually the worst category in terms of disease, the extent at which we think the disease would progress. So let's move on to the evidence. Okay, so the basis of the evidence was firstly discussed when the EFP and the AAP sat together to discuss the new classification and replace the old 1999 classification with a new one, where we're looking at stages and grading of periodontal diseases, and we no longer speak of chronic or aggressive forms of periodontal diseases. And when they got to the consensus group on discussing diabetes mellitus and periodontitis and its relationship, they recognized that there are 3 tiers of this relationship, and that the evidence that we need to examine is that of epidemiological studies, firstly, to show association and that these diseases actually occur together or co-occur. The second leg of evidence lies in mechanistic links, and a lot of those studies involve inflammatory mediators, which I warn you, I will not go into too much detail, but I have summarized for you. And then largely intervention studies. So intervention studies show us that when we treat periodontal disease, does it make the control of a diabetic person a lot easier or not? So can that assist or not? And that is what we'll be discussing now. Okay, so when we're looking at epidemiological evidence, the first question that the consensus group led by Mariano Sanz had presented is periodontitis associated with elevated glucose levels in diabetes mellitus? And what they found was that periodontitis has a significant impact on diabetic control and incidence of diabetes in individuals that are not previously affected by diabetes. That patients with type 2 diabetes exhibit a deterioration of their glycemic control and a higher degree of complications of their diabetes when they have periodontitis. The second question that they looked to answer was, is periodontitis associated with poorer glycemic control in type 2 diabetic mellitus patients? And in 3 studies that covered over 700 patients, it was found that periodontitis was significantly associated with poorer glycemic control in type 2 diabetics. And 2 studies showed that there was no significant increase in HbA1c, and some studies showed elevated insulin resistance, or that action of insulin was not working well in this patient group. Unfortunately, to answer the question of is periodontitis associated with the poorer glycemic control in type 1 patients, we find that there's insufficient data to basically conclude whether there is a link in type 1 patients. So it's less well defined than in the type 2 patient group. And that was based on the review by Mariano Sanz, as well as a systematic review by Graziani et al. In 2017. Furthermore, the other questions to ask were, is periodontitis associated with more diabetic complications in persons who are diabetic? And we had 14 studies of over 31,000 patients, almost 32,000 patients, showed that retinopathies were significantly associated with periodontitis, with an odds ratio of up to 2.8. We also found that the severity of periodontitis and retinopathy was directionally proportional to each other. So the more severe the periodontitis, the more severe the retinopathy was in those persons. And periodontitis was also associated with more renal complications in both type 1 and type 2 diabetics. That there was a significant association of neuropathic foot ulcerations in patients with severe periodontitis with an odds ratio of up to 2.6. And that cardiovascular complications were significantly associated in type 2 patients with severe periodontitis with an odds ratio of 2.6. And that mortality in type 2 diabetics were elevated significantly in those with periodontitis. The other group of diabetic patients that were reviewed was those with gestational diabetes. And as was the case with the type 1 data, there was insufficient data within that systematic review to support the fact that periodontitis was in fact associated with a poorer glycemic control in those subset of patients. What about the reverse? Is the risk for type 2 diabetes higher in those with periodontitis versus that of periodontal health? And the answer came from a study or numerous studies across the US, Japan, and Taiwan, which included more than 77,000 participants, which showed that there was an elevated risk for the development of type 2 diabetes as well as pre-diabetes, which is hallmarked by insulin resistance in persons with periodontitis. And the second question was, is there a higher incidence of gestational diabetes in pregnant women with periodontitis? And there were two studies that actually showed an association, though they were not completely conclusive on that matter. I always like to see what was done in South Africa because it helps us also to determine what we can be doing based at a university and at an institute for training and research. And in 2006, Thabit Beck, another colleague within the Perio Society, et al. Found that periodontal disease was more common in poorly controlled type 2 diabetics. And that study was conducted in a resource-poor rural setting in KwaZulu-Natal back in 2005, 2006. And then we have two studies that hailed from UWC. The second by Matu et al. Was a case-controlled study that found that type 2 diabetic mellitus patients had significantly higher GI scores and PI scores as well as clinical attachment loss than non-diabetic patients. And then a third, also from UWC, was a case-controlled study and dissertation by an MSc student in periodontology, James Hislop, where 47 type 2 females were compared to 16 non-diabetic females. In this study, they used Ramford teeth only, as they did in the Matu study as well. And it was found that the non-diabetic control group had less gingivitis than the type 2 diabetic females, and that they had less pocket depths in the type 2 females, and that they had less plaque than the type 2 females. So it could be that the hyperinflammatory responses was when the inflammation was resulting or perpetuating the dysbiosis, causing a greater plaque accumulation in that group of patients. But this was a small study, and certainly we can do with larger population studies within South Africa. Let's move on to the mechanistic links. Okay, so the first is, for periodontitis to happen, you do need a biofilm. So the oral microbiome, as we now refer to it, has and plays a significant role in the pathogenesis of periodontitis. And the biological mechanisms that are investigated along the mechanistic links has to align with the outcomes of periodontitis, which is initiated by the biofilm, as I've just mentioned, and then dependent upon inflammatory mechanisms within the host, and ultimately ends in the loss of connective tissue, including bone. And therefore, the oral microbial flora, as well as the inflammatory mediators, are included in these mechanistic investigations. Inflammatory mediators in periodontal tissues play a key role in the pathogenesis of periodontitis. And amongst these that have been investigated include cytokines, adipokines, advanced glycation end products, as well as their receptors, The homeostasis of bone plays a role, as well as microRNAs, which is different to messenger RNAs. And just to summarize what those are, the term cytokine is basically a cell signaling molecule, and that's what it refers to, and it aids cell-to-cell communication in immune responses, and they stimulate the movement of cells toward the site of inflammation, toward the site of infection, and towards trauma. So they can be pro-inflammatory, and they can also be anti-inflammatory to basically cause homeostasis and control inflammation. Adipokines, which is it's like a tongue twister, is defined as a group of over 600 bioactive molecules that is produced by adipose tissue, and it acts as paracrine and endocrine hormones, and they are also important in diverse processes, and amongst which are inflammation and endothelial function, which are important in terms of inflammation and pathogenesis of both diabetes as well as periodontitis. And when we speak of advanced glycation end products, we speak about proteins or lipids that become glycated after their exposure to sugars. And these end products are prevalent in diabetics in their vasculature, and they contribute to the development of atherosclerosis within diabetes mellitus. When we look at bone homeostasis, this is linked to the function of osteoblasts and osteoclasts, which in turn are regulated by inflammatory mediators. And your pro-inflammatory mediators basically stimulate the release or the action of osteoclasts, which result in bone resorption, the hallmark of periodontitis. And then you get microRNA, which has the ability to silence messenger RNA and also then interrupt the translation of messenger RNA into proteins. And these molecules have also been implicated in the pathogenesis of type 1 and type 2 diabetes mellitus, as well as periodontitis. Okay, so this picture is a summary of basically the mechanistic links that have been investigated to explain the relationship between diabetes and periodontitis. And in recent years, the knowledge of the microbiome ecology in health and disease has developed greatly. And with the understanding that disturbance in a healthy metabolic state may affect the gentle equilibrium between the host and the oral commensal microbiome. Once the steady state is disrupted, you get dysbiosis occurring, as I've mentioned before, and inflammation may actually initiate and encourage the propagation of pathogens, including pathogen-inducing inflammation. And as such, diabetes may have a tremendous impact on the periodontal homeostasis via the changes that hyperglycemia causes to the oral microbiome. Hyperglycemia also in diabetes drives the irreversible formation of advanced glycation M products, as seen on the top right of the picture over there. And they have a direct pro-inflammatory and pro-oxidant effect on cells. And when advanced glycation M products bind to their signaling receptors on cells like fibroblasts and leukocytes, they change the cellular phenotype and function, and they basically enhance inflammation and oxidative stress. And they further drive glycation M product formation, and they impair tissue repair. So the expression of advanced glycation M products concomitant with markers of oxidant stress was demonstrated for the first time in gingival tissues of diabetic patients with periodontitis by Schmidt et al. And subsequently, advanced glycation M product proteins were found in the saliva of subjects with diabetes and were linked to the accumulation of dental plaque. While serum advanced glycation M product levels were shown to be associated with the severity of periodontitis in subjects with type 2 studies. Very interesting is that in mouse studies, the blocking of the receptors for advanced glycation M products in animals with diabetes decreased the levels of inflammatory cytokines and matrix metalloproteinases in their gingival tissues, and actually suppressed experimental bone loss. So the action of advanced glycation end product and their ability to actually connect with their receptors is a key in the pathogenesis of inflammatory responses within periodontitis. And the biological endpoint of periodontal disease is the irreversible loss of periodontal supporting tissues, including alveolar bone. And bone resorption is mainly mediated by RANK-L, which is a ligand through the receptor called RANK. And RANK is expressed mainly on pre-osteoclasts, which then become osteoclasts, and they basically are responsible for the breakdown of alveolar bone. The third leg of evidence in terms of studies or intervention studies. And intervention studies set out to determine whether the intervention of a disease would improve the outcome of its comorbid partner or its comorbid friend, as we earlier coined this relationship to be. Marianos and Koromantzos assessed and rated 9 systematic reviews published between 2013 and 2017. And the studies that evaluated the reduction in glycated hemoglobin at 3 to 4 months after periodontal treatment showed a reduction in glycated hemoglobin ranging from 0.27% to more than 1%. And about a third of these studies reported data from 6 months after periodontal treatment, which showed a smaller degree of glycated hemoglobin reduction ranging between 0.02 to 1.18%. There was also a reduction in fasting plasma glucose at 3 to 4 months, which was consistent with the reduction in glycated hemoglobin. And the results of these meta-analyses indicate that effective non-surgical periodontal treatment in people with diabetes resulted in statistically significant reduction of up to 0.65% in glycated hemoglobin at 3 months. And such a reduction in hyperglycemia, if prolonged, may actually reduce the ability of that diabetic patient to develop complications and thereby improving the quality of life. A recent periodontal treatment study which showed HbA1c reduction over a period of time, over a period of 12 months, was conducted to evaluate the role of local inflammation in the systemic inflammatory burden and glycemic control in patients with type 2 diabetes. And the findings of this 12-month follow-up study following periodontal treatment are shown in this figure. And the study included poorly controlled patients with type 2 diabetes and severe periodontal disease, and there were 30 persons in the sample. And the periodontal treatment was diagnosed to achieve a complete or near complete elimination of oral inflammation, and it consisted of a combination of non-surgical as well as surgical treatment with adjunctive use of systemic and local antibiotics and the extraction of hopeless teeth. After this comprehensive treatment, patients were clinically monitored every 2 months and received repeat supportive periodontal therapy and oral maintenance as they needed, as well as the assessment of glycated hemoglobin levels. Paralleling the improvement in periodontal health, which was the reduction in pocket depth, the reduction in bleeding on probing, attachment level gains, glycemic control measured by fasting serum glucose, as well as glycated hemoglobin showed a steady decrease following periodontal therapy, and this was statistically significant. The cumulative impact of continuous and strict periodontal follow-up and maintenance every 2 months following active treatment resulted in an even greater reduction in glycated hemoglobin levels at 12 months. And the change in this glycemic parameters in response to periodontal treatment demonstrated that the infection and inflammation associated with periodontal disease significantly contributed to the inflammatory burden and negatively impacted the efficiency of pharmacological control in type 2 diabetes, and that a reduction of this inflammation by rigorous periodontal treatment can result in better glycemic control. So we certainly have a role to play. I'm now going to move on briefly to 2 case examples, and I must just apologize because the first case is not very well documented and I only have 1 clinical picture because the patient was unfortunately lost to follow-up. But what I saw, this was very many years ago, was a 32-year-old male patient, and he presented complaining about bad breath, and he didn't like the look of his gums. He admitted to neglect due to working night shift. In fact, I remember that he worked in sort of the nightlife industry and generally had a very unhealthy lifestyle. He was unaware of any medical conditions. He certainly never ever saw a medical doctor. He was, however, obese, and his gingival presentation was that of generalized edematous and erythematous gingiva. His plaque and bleeding on probing scores was skyrocketed through the roof, and so were his pocket depths. And when I saw this case, I remember being a very junior registrar at the time, and I thought, but some alarm bells are being set off here, because I see periodontitis cases every day, and certainly their gingiva does not look like this. And there's something that I need to do to investigate the reason for this. And this is why when we do periodontal treatment for any periodontal patient, we, in our head somewhere, manage or draw up our treatment plans according to the phases of periodontal treatment as outlined in the Linde textbook. And what I'm going to present in terms of this case today is only the systemic phase. And the systemic phase is basically the initial phase, not the initial phase, but it's the first phase, sorry, of periodontal treatment. And it basically serves to tell us, is this patient safe to treat for themselves? Is they safe to treat for the dental team? Are there any underlying systemic conditions that need to be monitored or that the patient doesn't even know about, as was the case here? So I sent the patient off for a blood test, and I basically requested a fasting glucose, and the result was 33 millimoles per liter, and the norm is less than 7.8. I also requested a full blood count, but that was marginally, that was not really conclusive, and did not add any diagnostic value to this case. I then referred him to a physician who prescribed metformin and diet modifications, and he started metformin, and I think I only managed to do a supragingival scale for this patient because he never returned for his treatment. And then he dropped from the gingiva, slightly improved just after the initial scaling, as you can see on the right. But his diabetic control improved to 9 millimoles per liter after the metformin was also introduced in terms of treatment. The second case is somewhat better documented, and that's thanks to our registrar who you met last week, Dr. Spongile Mahlangu, this is her case. This is a 24-year-old female who complained of dull pain. She is a known type 1 diabetic and insulin dependent. She's a non-smoker, thankfully, and non-alcohol user. Her oral hygiene practices included brushing once a day with no interdental care and the use of Listerine, so there was room for improvement there. There was no extra oral abnormalities detected, and her plaque scores were 21%, and the bleeding on probing was quite high at 46%. Those are her clinical pictures with the frontal and somewhat lateral view in occlusion, when you can actually see that there could potentially be some occlusal interference over here, which unfortunately I don't have a clinical picture of. And there's some marginal plaque that you could see quite readily in this case. Her marginal gingiva in this area was erythematous, slightly edematous over there with the diastema, and certainly her teeth have somewhat moved in the process of this disease. So what we did was we then do a full periodontal chart whereby we assess a few parameters to do a full periodontal evaluation, including probing depth. We measure any existence of recession, plaque scores, bleeding scores, enification involvement, mobilities, and so forth. In the maxilla, we had some mild pockets of 4 and 5 that were also associated with an angular alveolar bone loss between 1.1 and 2.1, and a mild pocket at 1.7 distally. Then when you're looking at the mandible, which was the area of most concern, we had pockets of up to 6 millimeters with quite a lot of plaque and bleeding on probing in this area, and also some angular bone defects that we saw on the radiograph. I don't have the periapicals available here. And there was also mobility of 2 associated with these mandibular incisors. Okay, so when we're looking, we got to a, sorry, before I get to the treatment, we got to a diagnosis of generalized periodontitis, stage 3, grade C, unstable. I should have added there, which I did not add. So our periodontal disease diagnoses are becoming quite long these days with the new classification. But we once again follow the route and we start with systemic phase of treatment. And just because she tells us she's type 1 does not mean that we know and that she knows how well controlled she is. So routinely, we send her for an HbA1c as part of our systemic phase of therapy. And we note that she's in fact not well controlled with an HbA1c of 13.1%. And that is why she earned the grade C category. In terms of the initial phase of treatment therapy, we had to augment her oral hygiene routine because if you remember correctly, she was only brushing once a day. She was not using any interdental care, and perhaps the choice of mouthwash had to be changed for a period of time to contain a chlorhexidine product for anti-plaque effect in this particular patient. Scaling and root plating was done under local anesthetic. As well as a minor occlusal adjustment due to occlusal interferences in the mandibular incisal area. And the mobile teeth was splintered. And we usually reevaluate for the period of 4 to 6 weeks after this initial phase of therapy to basically determine whether the patient is ready to go either into a supportive phase, a corrective phase, or go back to initial phase. So after this reevaluation, we did find persistent pockets at the mandibular incisors, and the patient is now indicated for open flap debridement with regeneration should the intrabony defects allow that, the anatomy of the intrabony defects allow for GTR procedures in that area. And only once we have basically determined that there are no pockets left, or we have closed pockets, which are readings of 4 millimeters without bleeding on probing, do we then progress to a supportive periodontal therapy, or what is traditionally known as the maintenance phase of therapy. So what are the conclusions and recommendations that I came across in the literature, and then things that I would suggest? Well, first of all, Mariano Sanz suggested a criteria for testing diabetes or prediabetes in asymptomatic adults. And this was based on Diabetic Care for 2017. And it is suggested that testing should be considered in overweight or obese persons with a BMI of above 25 kilograms per meter squared. And also in adults who are obese and have a first-degree relative with diabetes, have an ethnic high-risk, belong to an ethnic high-risk group, women who were previously diagnosed with gestational diabetes because they have a third likely chance of actually developing type 2 diabetes later on in life, persons with a history of cardiovascular disease, persons who are obese and hypertensive definitely need to be regularly tested, those with high cholesterol, women with a history of polycystic ovary syndrome, persons who are generally physically inactive, and have other clinical conditions such as insulin resistance. And all patients should be tested above the age of 45, regardless of whether they are obese or not. And if results are normal, testing ought to be repeated at a minimum of 3-year levels, or 3-year intervals, sorry, with consideration for more frequent testing depending on the initial results. So those with prediabetes should be tested annually and not just every 3 years. In terms of the review itself and the relationship between perio and diabetes, I think us as dentists should be aware of the worsening effect of periodontitis on the glycemic control and the deterioration of patients who are diabetic in terms of their complications, that the cumulative impact of continuous strict periodontal follow-up and maintenance every 2 months following your active treatment can result in the reduction of HbA1c levels over a 12-month period. And we need to bear in mind that the work that we do is actually quite significant, because even a 0.4% reduction in HbA1c, and some of those studies showed a reduction of over 1%, is comparable with the addition of a second anti-glycemic medication in that particular patient. So periodontal intervention is thus significant. And then in terms of a research recommendation going forward, that there is more epidemiological studies investigating this relationship of periodontitis and type 1 diabetes, as well as gestational diabetes required, both worldwide, but definitely within South Africa. And I think we even have room to enlarge our epidemiological studies in our type 2 patient group, which is currently weighing heavy on our public health sector. So that's the end of my presentation, and I will now hand over to my fellow colleagues.
Thank you very much, Dr. Jeftha, for an extremely informative lecture. I think you really highlighted the importance of us taking into consideration our patients' periodontal status when it comes to management of our patients. And yes, the bidirectional relationship has been proven in the literature, and you really highlighted that for us tonight. I've got some questions here from our attendees. Okay, one of the first questions was any of your sample patients tested for HIV? And how would this have influenced your results and treatment recommendations?
Sinead, the sound is not traveling too well my side. I did not hear the question quite clearly. It's about the relationship or the addition of HIV. I didn't hear. If you could just repeat that.
Okay, let me just see. Is that better?
Much better, thank you.
Okay, my apologies for that. So let me just repeat the question. The question was any of your sample patients tested for HIV, and how would this have influenced your results and treatment recommendations?
Okay, as far as I know, none of the review articles that I drew from included patients who were HIV positive. So I don't know, there were no recommendations regarding HIV in this particular patient group. And I think a lot of the research is done purely in diabetics with periodontitis. So there are no recommendations other than the normal recommendations of HIV that we see in persons who are HIV. HIV does not put you at a higher risk for developing periodontitis. It does put you at a higher risk if it's uncontrolled to developing necrotizing periodontal diseases. So in that case, I think if an HIV positive person who is uncontrolled, not taking ARV therapies, also has diabetes and is poorly controlled, I can imagine that that case becomes a lot more complicated to manage. But with the initiation of antiretroviral therapy, we usually have quite a good resolution of acute infections within our HIV population, as we can see in our clinics, and any other sort of other manifestations of HIV, which we now rarely see because our patients are fairly well controlled. But unfortunately, none of the studies that I have cited considered or would have included an HIV cohort in their population.
Thank you for that. I'll move on to the next question. Here is a statement. My patient who has confirmed type 2 diabetes asked me if this disease can be reversed, and if this in turn will reverse the oral symptoms of alveolar bone loss, gingivitis, mobile teeth, etc. The patient further asked if cutting out all junk foods, sugar-laden foods, drinks, Coca-Cola, fruit juice, and a high carbohydrate diet will help with reversing this disease and hence the diabetes. How would you have responded to my patient?
I would tell my patient that that's a loaded question, certainly for an oral health professional. and then maybe we needed some input from our dietitian colleagues. But what I do and what I can say is that lifestyle and certainly the management of all factors that affect your BMI and affect obesity definitely do play a role. And there is sufficient evidence that I've not presented here, obviously, about a low carbohydrate or high fat, low carbohydrate diet in terms of the reversal of type 2 diabetes. But I don't think that I'm an expert in that. And I think we should probably bring our medical colleagues or dietitians in on that. In terms of the reversal of periodontal diseases, gingivitis is reversible. Periodontitis is unfortunately not reversible because we cannot give back bone that has been lost. But what we can do is we can arrest bone loss in persons with periodontitis. And that is exactly what our non-surgical and our surgical therapies do, whether you're diabetic or not. And certainly now we have evidence for that type 2 patient in your chair to say that with this treatment of periodontitis, we can actually reduce your need for elevated drug treatment because we can significantly lower your ability to have metabolic control just based on our treatment and the removal of the inflammatory factor that your oral disease presents to the rest of your body and your system.
Thank you for that. Here's another question. Since there is a link between periodontal disease and diabetes, is there any study to show a lower incidence of diabetes in edentulous patients?
That's actually a very clever question, and I may actually have to call on some more minds to help me answer this. From the outset, I can tell you that when we remove teeth, we change the oral microbiome. So we actually obviously removing that, and it doesn't have an effect at all, because if you have no teeth, you have no periodontitis. If the removal of that teeth due to periodontitis has reduced the inflammatory load in that particular person, then yes, perhaps it could help that person maintain better health. But I don't know of any evidence that shows that just because you're edentulous, you actually have a better control of your diabetes, because it's so multifactorial and there are other factors that do play a role. I don't know if my fellow panelists want to actually put in some answers there too.
Yeah, I definitely agree with the response that you gave there. I'm also not aware of any studies that specifically address that. But yes, definitely if the inflammatory load is decreased and we do have a change in the oral microbiome, logically a person would think that the diabetic control would potentially be better in those patients. Just another question. Please briefly discuss the relationship between periodontitis, the stimulation of the C-reactive protein, and cardiac disease.
Okay, I'm really being tested here now. I cannot quote subjects off the top of my head right now, but I know that C-reactive protein is an inflammatory mediator that would highlight elevated risk for the development of cardiac disease. And I do know that it is elevated in persons with active periodontitis for the very reason of pro-inflammatory or hyper-inflammatory response, which then obviously plays a role in the whole pathogenesis pathway. In terms of disabling your microbiome, making it dysbiotic, and then creating the vicious cycle and the development of a hyperinflammatory individual. So yes, we do know that C-reactive protein has been found to be elevated in persons with periodontitis, and perhaps this question begs the need for us to actually have the topic of periodontitis and cardiovascular disease, which I actually haven't reviewed for a few years now, but that is certainly topical as well.
Yes, thank you. That is definitely highlighted in some of the other questions that also come through, where participants are asking, can you discuss the relationship between diabetes and cardiovascular disease in periodontally compromised patients? I don't know if you have anything additional you want to add there, but this is potentially something I think we should look at for a topic for another webinar.
I know that persons with periodontitis and diabetes and the complication of cardiovascular disease, there is a higher percentage in terms of mortality rate for a diabetic patient with cardiovascular sort of complications than who also has periodontitis. I know that periodontitis is an indicator for higher mortality. I think it was 16% if I remember correctly, but I have it here somewhere. I'm not going to sift through my notes right now, but I don't remember the percentage offhand.
Okay, then we have someone who's just referring to the second case. So that was the case with the lower anteriors. The participant is saying that it was mentioned that the patient's incisors were splintered. Is it possible for there to be sufficient attachment gain for the mobility to improve from grade 2 for the splint to be removed? Okay,
so is the question, are they asking that will the splint cause attachment gain? Is that the question?
Yes, that seems to be. Is it possible for there to be sufficient attachment gain for the mobility to improve from grade 2 for the splint to be removed? So yes, you could see that from two perspectives regarding either the splint, or I'm not sure if they're referring to the treatment that you're carrying out and then there being an improvement in the mobility of the tooth.
Okay, so the role of the splint is basically to, first of all, you splint the mobile teeth to a tooth that is stable and not mobile. And the reason for this is that you are then spreading the load over a larger area and not on a tooth that is already mobile with a reduced periodontium. Whether or not the splint can be removed is a matter of time will tell that, because that will depend on the amount of attachment that we are able to gain after treatment. And we'll only know that after we've completed the corrective phase, and we have not yet entered the corrective phase for that particular case. So just thinking of past experience of cases, yes, it is possible that with a correctly administered GTR procedure, with adequate follow-up of that patient and routine maintenance periodontal care, you can actually gain some attachment and improve the mobility of that particular tooth. But then you need to make sure that all your occlusal issues are also sorted, because those usually exacerbate those type of clinical scenarios.
Okay, the next question is, would you recommend a dentectomy as a means of controlling the uncontrolled diabetes patient?
Not as a rule of thumb and not as a blanket statement, no. I think we still look at teeth, and what I did not show you in that case was how we evaluate all our perio cases is that we actually go through a tooth-by-tooth prognosis. And that prognosis is dependent on a certain number of factors. And regardless of whether the patient is diabetic or not, if there's a sufficient residual alveolar bone and there's no bone loss to the apex, and we are still able to rehabilitate that tooth and save that tooth, we actually definitely will, because you'll be amazed at what turnaround is possible with the correct periodontal care. So we cannot just use a blanket statement to say that every tooth that is affected needs to be extracted. No, I don't agree with that at all. Unless the tooth is has almost no alveolar bone left and has lost bone to the apex.
Okay, then we have another question here. Does the content and influence of the gut microbiome supersede the influence of the oral microbiome on the pathogenesis of type 2 diabetes?
That's a very interesting question, and I actually don't have an answer for that, because I did not review the relationship between the gut biome with the oral microbiome, and there was certainly no allowances made for that in any of the articles that were reviewed for this presentation. and that are available in the periodontal literature at that moment in time. So thank you for highlighting that as something that I definitely will have to look into.
We have another question. Are implants contraindicated in patients with diabetes?
No. If your patient is a well-controlled diabetic, you can definitely do implant surgery for that particular patient. I would not, however, do implant surgery in a patient that is poorly diabetic or poorly controlled diabetic. I would first work together with the physician to basically get the patient to an adequate level of control before implementing implant surgery in that patient.
Dr. Naidu, would you like to take over from here?
Sunay, you can carry on. I'm not seeing the questions so easily, so you can carry on. If you're seeing them well, please go ahead.
Okay, no problem. I just didn't want to leave you there in the background.
No, it's all right. Carry on.
No problem. Here's another question, Dr. Jeftha. Do you recommend peroxide rinses to patients with gingivitis?
No, at the moment, the standard of care and the protocols that we use at the university is for chlorhexidine mouth rinse in terms of antibacterial care for gingivitis. So we do not use peroxide at the moment.
Okay, I think this is possibly the same attendee that's also asking regarding the gut microbiome again. Did you consider working on the quality of the gut microbiome than to put patients on metformin?
I don't think that that is something that I would make a call on. I think the ability or the treatment of the diabetes and the metformin lies in the hands of our medical specialists and our medical colleagues. And that decision is best made with them. And as I said earlier, the review articles that I had prepared for this presentation, and to my knowledge, do not actually take into consideration the gut microbiome.
Thank you very much, Dr. Jeftha. That seems to be the end of the questions as far as I can see.
Thank you. Thank you, Dr. Mulder.
Thank you, Dr. Mulder. Let me see if I can get back online. Thank you. Anthea, thank you for a lovely, lovely presentation. Some of the material was quite tough to follow, quite technical material, but superbly interesting. You certainly didn't sugarcoat anything, I must say. So from that point of view, thank you for highlighting that. If I can add one final point from the questions and so on that came through, perhaps it's worth noting that the relationship between periodontitis and any of the systemic conditions, be it cardiovascular disease, diabetes, kidney-related stuff, lung-related stuff, it's not a causal relationship.
No.
And I think what's so important to understand is that all of these conditions that we're referring to have a multifactorial etiology. And periodontitis per se is one leg of that multifactorial etiology. So it's not so much a matter of saying, let's eliminate this or eliminate that at the expense of something else. In general, you've got to look at all those risk factors and you've got to manage each of those risk factors as best as one can. I think if one looks at it from that point of view and understand that so many of those conditions share common pathways in terms of the inflammatory cascade, then I think all of a sudden the answers to those questions become so much more revealing in the sense that we're not looking for a magic bullet solution by saying we must do it this way and then we don't have to do all the other stuff and so on. I think we have to do all the other stuff. And from a more practical point of view, we need in our practices with our patients, I think, to more involve the degree of glycemic control within our care of our patients. The simple test of the HbA1c, I think, is a fantastic test to empower patients to understand their control. It gives them an opportunity to look at their diabetes, and it gives them then an opportunity to also play a role in being active participants in the control of their periodontitis. The hardest thing to do is to get patients to become involved in their treatment. If we try, I think, to bring patients with us into the treatment and treat them together with them, rather than to do treatment just to them, I think linking the Diabetes Association and all the other things, which I'm sure we'll get to in other lectures, but for the purpose of this lecture, linking the diabetes with the periodontitis as a start in terms of motivating overall general health, that alone, I think, takes us a big step forward in landing up with more motivated patients who are empowered to look after their own health. So thank you so much for highlighting this point. I know it was a tough lecture to prepare. It's not one of those lectures where you can show beautiful multiple slides of before and after and so on, because it's quite a medical orientated lecture. But we are really so grateful for you taking the time to share with this. Also, I must apologize to you and to all the viewers for tonight for the technical glitches. I think if I can just say to people tuning in, which I didn't know until a couple of months ago, behind the scenes in terms of putting these webinars together, there's at least 4, 5, 6 people who are doing serious things from days and weeks before the webinar. And things are tested and double checked and retested and everything. And then you go live and then you find, for example, something just doesn't work. And that's the beauty of all the technology that we have. But thank you to everybody listening for being patient and re-logging on. And I'm sure it won't be the last time that we're going to have these glitches, but really thank you for your patience and understanding. Before we log off, I hope there will be a little video clip that was supposed to play. Hopefully it will play. And shortly after that video clip, there's going to be a survey. Please just stay tuned in and fill the survey. It will only take a few seconds. And to everybody, don't forget, next week, same time, we have another webinar, and we'll see you then. Good night, everybody, and thank you for tuning in.
Gum problems? Neglecting your gums can start a chain reaction leading to serious problems. Meridol. The Swiss gum expert helps fight the cause of gum problems, so they don't get worse. Meridol. Healthy gums, healthy teeth. Exclusively available in pharmacies.
Thank you, everybody.
You're welcome. Thank you so much.
My pleasure. Thank you, Sunay.
Thank you,
Thank you,
Anthea.
Ronan. Tsepo, I hope your electrical problems are sorted out.
Sure.
Thank you, Sunay.
Thank you, Ronan.
Thank you, everybody.
I must say,
The session officially ended.
Very well with the questions.
Yes.
And Anthea, for your to you on your side, the questions were not easy questions, but you answered so well, eh?
I know, they were like out to get me, weren't they?
No, it's always, the problem is everybody reads things, and the biome story is really becoming a big deal, eh?
A very big deal.
Internationally, I mean, you can't read solid stuff these days with the biome thing. It was interesting, some months ago, there was an article on PG and Parkinson's. So, I mean, they're pushing these things to new levels. And I think the next 10, 15 years, the microbiome, and not just the oral microbiome, is going to be the new place to be for all the stuff, I think. I think the first 20 odd years that we've had now has just been the starter. The interesting stuff is going to come in the next 10, 15 years, I think. But listen, you did so well. Thank you to everybody.
Thank you.
In the background, there's gave you a little bit of a heart attack through this whole thing. But I'm sure Anthea will be happy to do the cardiovascular thing at some point.
Yeah, I wouldn't mind.
About 15 years ago, I think it was in Cape Town, the South African Society for, I think, Cardiology, or something like that. And the Perio Society held a joint meeting. And it was a really... Awesome. Stepo, if you're still there...
I'm still here, Doc.
Oh, good. Sorry for all your drama. But I think it's all well. And in the end, I think everybody logged on again. I think it was okay.
No, we did. We had a full attendance. So I'm quite excited about that and happy about that.
Yeah, so, listen, I mean, these things happen. And power failures and so on are going to happen. It won't be... for sure, it won't be the last time. So I think people forgive us for that. Ruth, thank you so much for all your help.
Doctor, can I end the session? We still have about 283 people that are loitering, but I think once we end, they will go.
Okay.
Thank you, love.
All right. Thank you so much.
So much.
Thank you, everyone. Good night. Thank you for attending.
Good night.
We're going to end the session. Good night.
Thank you.